The Delhi Heart Lung Institute where I'm working, and I'll be discussing with very uncommon topic which is discussed in intensive care meetings, the management of severe hemoptysis. And perhaps this is the first time that we are discussing a topic like management hemoptysis, which is so common in emergency that comes to us in daily day-to-day practice. Fortunately, the hemoptysis in most of the patient is mild to moderate, which is usually self-limiting and stops on its own or by some conservative management. And you feel very happy about it. But the problem arises when the patient comes with a severe hemoptysis, because severe hemoptysis is associated with very high mortality to the tune of 50 to 100% in various studies. And this is very, very scary. And there's something that we have to do to stop this severe bout of hemoptysis. Now, coming to the definition, there is no general consensus. What exactly is a severe hemoptysis or massive hemoptysis? But it's generally believed that if a patient expected to resource more than 600 ml of blood in 24 hours, that is considered to be severe hemoptysis. But perhaps a better definition is when any amount of hemoptysis which can prove fatal, which could be life-threatening, should be considered as severe hemoptysis. Depending on the functional state of the patient, the lung reserve of the patient, the comorbidities, the cough reflex of the patient. And whenever you feel that this amount of hemoptysis is likely to be serious, it could be life-threatening, then you have to intervene to stop the hemoptysis as early as possible. Because you should beware that it is an emergency. And as I said, the conservative management of massive hemoptysis carries a mortality of 50 to 100%. If you treat this patient with the hemostatistics, the cough suppressants, and the sedatives, then possibly you may lose patient very, very quickly. The important thing is the cause of death is usually asphyxiation and not exsanguination. It is not exactly the amount of blood. It is the inability of the patient to clear off the blood from the air passages that kills the patient. The patient is down in his own blood. There's flooding of blood in the airways, the oral cavity, the nose, and patient just chokes in his own blood and dies. And therefore, it is to be taken as a very serious condition. Now, to your surprise, the definitive treatment of massive hemoptysis is surgery. But this is the fact. Surgery is the definitive treatment in the management of severe hemoptysis. So what you need to do is to take these patients for thoracotomy and dissection of the source of bleeding, and this would be the ideal management. But the problem is, the surgery would be useful only in patients where the patient's got a localized disease and has got enough reserves. Is fit for surgery. That is also very important. If there's a bilateral disease, then you're not sure which segment you would remove and which segment would not bleed after the removal of that diseased area. And surgery is considered to be the treatment of choice for the management of hemoptysis due to leaking aortic aneurysms, selected cases of arteriovenous malformations, hydrated cyst, bronchial adenoma, or mycetoma. Now, this is a patient who is an ideal candidate for surgery. He's got a cavity in the right upper lobe and is bleeding profusely. It becomes very simple. You ask the surgeon, the patient is taken to the OT, and the right upper lobectomy is done, and the source control is done, and the patient is relieved of hemoptysis forever. But if the patient has got a bilateral disease like this bronchiectasis, suppose the patient is bleeding from the right side, if you remove right side of the lung, then you're not sure whether the patient would not bleed again. There's always a possibility he can bleed from the left side. And these are the patients who are not the ideal candidates for surgery, and where, the real problem arises. The other relative contraindication surgery besides the bilateral pathology could be the pulmonary insufficiency. Many of these patients have got a destroyed lung, bilateral disease, COPDs, comorbidities like cardiovascular dysfunctions, and therefore they're not fit for surgery. And of course, in patients where you have got a bronchogenic carcinomas which are unsectable, these patients again come with a different problem and difficult challenge. The patients who have got unresectable bronchogenic carcinoma, there the management really requires some sort of expertise, and you would need the services of the interventional pulmonologist. The bronchial artery embolization offers a second best option after the surgery, particularly in these sets of patients where you've got a bilateral disease and the lung reserves of the patients are not good and they've got the comorbidities. And what you do here is that you do a descending thoracic aortogram, you use various kinds of the catheters like Simmons 1, Headhunter, Yashiro type microcatheters. And you catheterize the bronchial artery and do a bronchial artery angiography. And you can use these embolic materials like gelatin sponge and polyvinyl alcohol particles, which are most commonly used in clinical practice. If there is a large bleeder, then people prefer the stainless steel platinum coils. The problem is that there could be generally, the bronchial arteries arise from the descending thoracic aorta, but it can have multiple origins. It can arise from subclavian artery, it can arise from internal memory arteries, and therefore it may be difficult to cannulate the bronchial arteries, and to control the hemoptysis in these patients may be difficult. This is an example where the patient was bleeding from the right side, and the bronchial artery cannulation is done, and this was blocked using the gelatin sponge, and you can see the bronchial artery is not totally blocked, and this would control the hemoptysis in these patients. Another patient where again the right bronchial artery is responsible for the bleeding, and you can see there is a lesion in the right upper lobe which is vascular, and again this artery is blocked using gelatin sponge, and the bleeding stops. So bronchial artery embolization is very effective in controlling acute massive hemoptysis. The problem is that there is a lot of recurrence of the hemoptysis after bronchial artery embolization in these patients, and around 50% patients may recur in 4 or 5 years' time with hemoptysis if the source control is not done or if the underlying disease is not treated. Now, there is a role of endobronchial management in these patients, where you have different pulmonary interventions like balloon tamponade, use of glue therapy, laser photocoagulation, endobronchial brachytherapy, electrocautery, and organ plasma coagulation. The last 4 are basically used in the management of the bleeding bronchogenic carcinomas. And the first 2 we can use as a replacement for bronchial artery embolization and surgery in patients who are not really fit for surgery or where the facility of bronchial artery embolization is not known. For example, there is a balloon tamponade. It has the advantage of controlling the bleeding. What you do, you pass a balloon in the segment of the lobe which is bleeding, and what it causes, it controls the hemoptysis there, controls the bleeding there by the tamponade effect, and would also prevent the spillage of the side, and therefore would prevent the flooding of the contralateral lung, and this would allow effective ventilation and resuscitation. And many times balloon tamponade can be used to stabilize the patient before surgery and bronchial artery embolization. The various types of balloon catheters which are used are Fogarty catheter. If there is a segmental bronchus, you would use 4 French and 100 centimeter long the Fogarty catheter. And if there is a main stem bronchus, they can use 14 French Fogarty catheter. We have also used biliary extractor balloon catheters. We have also used Foley's catheter in a couple of cases to stop hemoptysis. And this is a Fitard catheter which was introduced in 1993, and it's very easy to use in the control of hemoptysis. And you can also use double lumen ventricular tube for the balloon tamponade. This is the extractor triple lumen retrieval balloon catheter which is used by gastroenterologists in their biliary procedures. This is the inflated tip of the balloon, and I show you one example. This is the patient who was bleeding from the left upper lobe which was destroyed. And what you do a bronchoscopy in these patients. And this video shows that the patient has got active bleeding. As you can see, the trachea is stained with blood, and the patient was bleeding from the upper division of the left upper lobe. And what you do here is that you pass a guide wire through the suction channel bronchoscope, and this guide wire is introduced into the bleeding segment. And the next thing that you do is remove the bronchoscope, keeping the guide wire in place in the bleeding segment. So here the bronchoscope is removed. So you're keeping the guide wire in place and bronchoscopy is being withdrawn, and the bronchoscope is then removed. And on the guide wire, what you do, you pass the balloon catheter under the bronchoscopic vision. As you can see, the patient is still having active hemoptysis. There is oozing of blood from the left major bronchus. And this is the balloon which is guided over the guide wire, and then the balloon is inflated in the bleeding segment. Here it is the inflated. And then this catheter is secured, and the catheter is kept there for 48 to 72 hours. And once the hemoptysis stops, you can remove this catheter. This is the picture where you can see that this is the balloon catheter lying in the left upper lobe. This is another picture where the catheter is lying in the left upper lobe. This is a patient who had bilateral apical disease, and here the surgery was not possible because of the comorbidity and the bilateral disease. 2 attempts of bronchial artery embolization failed in this patient. And the patient had a massive bleeding. He bled about a bucket, and he had to be intubated and resuscitated. And again, we did the bronchoscopy in this patient, found the bleeding was occurring from the left upper lobe, and we introduced the guide wire in the left upper lobe, and then the balloon catheter was passed over the guide wire and inflated. As you can see, this is the inflated balloon, and then this is the accumulated blood, which sort of causes the tamponade effect and controls the bleeding. And the patient had a very good outcome. This is another example where the Fogarty catheter is passed in the left lower bronchus in a destroyed lung. And this is a patient who had a right-sided bronchiectasis where the Fogarty catheter is there in the left major, the right bronchus intermedius for the tamponade effect. In a couple of cases, we have used Foley's catheter where there was a massive hemoptysis, and we used the Foley's catheter under the bronchoscopic guidance and passed the catheter in the left major bronchus, inflated it, and that could, stop the hemoptysis. This is the inflated Foley's catheter, and this was done under bronchoscopic guidance. It's usually a very safe procedure. There are hardly any complications. Some patients may have coughing, hoarseness. There could be granule tissue formation in the vocal cords. These could be self-limiting problems and really cause any difficulty in the patients. The major problems could be the dislocation and rupture of the balloon. Therefore, you must do a chest X-ray in these patients every 24 hours to look for the dislocation. In some cases, the ischemic mucosal injury is reported, but if you deflate the balloon every 12 hours or 24 hours, then chances of ischemic mucosal injury to the bronchus is avoided. And some patients, rarely you can have post-obstructive pneumonia. The review of literature suggests the balloon tamponade is quite effective, and this is the study published in Chest, where they passed Fogarty catheter in 10 consecutive patients. As you can see in this slide, the patient had massive hemoptysis, somebody having 950 ml of blood in 12 hours, somebody having 600 ml blood in 3 hours, 1200 ml blood in 12 hours, and the hemoptysis could be controlled in all the patients. This is the Frita catheter which I was talking about. This could be passed with the bronchoscope where you do need the help of the guide wire, and they made 30 attempts in 26 patients and were successful in all the attempts except for one patient. And this is the list of large number of studies which show that balloon tamponade is quite effective. So you can ask your interventional pulmonologist to do this procedure, and this could effectively control the hemoptysis. Now, endobronchial glue therapy is coming up quite widely in setup. My co-chairman has perhaps the largest work on use of glue therapy. This also works as a tamponading effect on the bleeding bronchus. I'm not a great proponent because generally it is used for mild to moderate hemoptysis, which I feel mostly is a self-limiting condition and doesn't require much of difficult management. This is a patient who was bleeding from the superior segment of the right lower lobe. And here, we instilled the glue and blocked the superior segment of the right lower lobe, which caused the tamponade effect and stopped the hemoptysis in this patient. Now, endobronchial growths are difficult problems, and these patients are, mostly in the terminal stages of life, and massive hemoptysis in these patients. And here you really need the help of the interventional pulmonologist, where you can do some deworking procedures like laser photocoagulation, endobronchial brachytherapy, electrocautery, and latest the argon plasma photocoagulation. By these techniques, you not only dework the tumor mass, but also stop the hemoptysis, and it also relieves the respiratory distress. Here's some of the examples. Photocoagulation, where this is the patient who was having a large growth in the right major bronchus. The growth was also protecting the lower part of the trachea, and it was a highly vascular tumor. And the patient was on ventilator. It was a difficult bleeding case and had episodes of hemoptysis with tumor mass using the laser probe. The tumor mass was debulked, and the hemoptysis could be controlled, and the patient could be weaned off the ventilator. And again, it's a very, very safe procedure. The excellent results are achieved in around 55 to 94%, and the major complication rate is reported to be less than 6%, and mortality is less than 2%. Endobronchial brachytherapy is another way by which you can, debulk the tumor masses and control hemoptysis, where what we do is pass the brachytherapy catheters intrabronchially, and then the iridium-192 source is used for the radiation of these patients, and what it does is causes the local debulking of the tumor mass and avoids the radiation of the surrounding tissues. This is the example where you've got the brachytherapy catheter and growth in the right, and as you can see, highly vascular, and he had recurrent hemoptysis. And this is how, through the suction channel of the bronchoscope, the brachytherapy catheters are passed. And this is the endobronchial view, bronchoscopic view, where the catheter is passed across the tumor growth. The catheters are secured. In this patient, we had passed 2 catheters, and then the patient is transferred to the radiotherapy unit, where do the planning and cause the local, undo the local radiation in these patients. This is another very interesting example where the patient had come with the recurrent hemoptysis, and as you can see, the patient had 3 large tumor masses, 2 like laddus, and they were not only causing respiratory distress but causing massive hemoptysis in these patients. And we used the electrocautery snaring in these patients. The tumor masses were debulked. The endobronchial patency is restored, as you can see. Introduction, argon plasma coagulation, which can be used as electrocautery procedure in controlling hemoptysis and debulking the tumor mass, and it doesn't have a deeper penetration, so chances of perforation of the bronchus are minimized. So these are the various techniques and various procedures which you can use in the management of hemoptysis. I have not intentionally discussed about the management of these patients, the resuscitation of these patients, which is like any massive bleeding, which you would, which you would manage using the fluids, using central lines. But I have talked specifically about the various procedures which can be used in controlling hemoptysis in these patients. Thank you very much.